we want to talk about empowering patients through data. And Deena, I'll start with you, because I think during this economic boom that we've had over the past several years, there's also been a technology boom. And we've seen a number of innovations and startups focused on bringing focus to and services to and technology to populations that were previously overlooked. The economy's shifting. Why aren't we going to lose that? Or are we?
It's a great question, John, and thank you for being a partner in putting together this wonderful event. You know, the fact that we now have vocabulary to talk about bivalent boosters and molecular testing, the fact that we now can speak like bona fide epidemiologists, the fact that we have, how many, 12,000 people here at this event today, these are not just tailwinds related to COVID. I think COVID has opened up an entirely new way of thinking about our bodies, our economy, our health as individuals and as populations. We'll talk more, and Neel will talk more about women's health in particular, but whether it's women's health, whether it's Medicaid innovation, whether it's consumer health testing, none of these are necessarily new innovations. Some of them are age old, but there is a renewed interest among individuals, among investors like myself and like Holly, who co-led Maven's latest round, to see that there is a real opportunity for value creation to also help improve lives and advance humanity. That's always been there, but it's now undoubtable, and I think this is just the beginning. We're just starting to see what's out.
Well, great, but I'm concerned, Neel, about what tends to happen when economies shift, right? It's the populations at the fringe who just started getting that good thing who start to lose it. It's just what I've seen happen. So you guys just raised this round I mentioned, $1.35 billion valuation, I believe. Given the times that we're in, congratulations being able to raise that now, but what do you do with it, right, to benefit the population that you're serving, and to what degree are the needs shifting even as you're getting ready to deploy that capital?
I mean, I think the unit economics have to work irrespective of the weather patterns. You know, and I don't think any business is immune to them necessarily. Let's just be honest. At the same time, I think that, to Deena's point, we're living in a moment now where I think there's greater recognition of long-standing problems. I think one of the things that COVID-19 did was take every inequity in our society and just throw it into a pressure cooker. And so, we're largely an employer benefits business. Right now, the labor markets are tight, but they'll relax at some point. By the way, this is really funny to me because I'm a doctor and I had no idea to talk like this like a year ago. But of course, some of what we're selling is like fertility benefits, which you could look at as a perk. But I think what's shifted in the last couple of years is whether it's fertility or pregnancy. I mean, these are fundamental. I mean, building a family is existential for people. And when you talk about the people who are most impacted by the gaps, if you want to call them, the crags in our system, it's people living at the intersection of geographic inequity, racial inequity, gender inequity. They all intersect in reproductive health. At the end of the day, the way to decrease costs is to make people healthier. And I don't really see employers uninstalling these benefits. They're among the most important, particularly from a DEI perspective.
Well, that's interesting. And Maulik, at Biofourmis, you're tackling this from another angle. Patients, people who are dealing with really acute, serious illnesses, being able to use technology to track how they're doing and deliver insights and care while they're at home, right? So how did you do with that during a period, right, when COVID made all kinds of care more difficult? And what do you see coming out of that period into whatever's next, where there's broader opportunity for other innovation to help out?
Great, thanks, John. I mean, I think, as you mentioned, one of the critical things that happened in the pandemic was the concern for patients going to the emergency rooms because of the risk of infections, and also the capacity constraints all the hospitals are facing because of shortage in staffing or just the overburdening of care. You look at the New York City example. One of the great things that CMS did is establish a waiver program for acute care in the home. And we were fortunate enough to ride those tailwinds to say, could you create a program where patients who qualify for inpatient hospitalization are able to actually be discharged to the home environment and get acute hospital level care in the home. If we think about that model though, there's a lot of things we do in the hospital that can't easily be replicated in the home. And how do you deliver that acute care safely and effectively? Because the biggest thing that could be a detriment to the entire sort of program is an adverse event or a patient death in the home. So these are Biofourmis. We've thought about the idea that could you use technology, both from a care delivery communication perspective, but a monitoring perspective, to actually monitor patients' physiology in as continuous as a fashion you would do in the hospital. And if you could do that, you could do that care effectively in the home and scale that program. So now there are 280 plus hospitals in the country that have gone to CMS waivers for acute care in the home. So that's actually scaled dramatically in less than 2 years. I'm confident that looking at the safety and the effectiveness of some of these programs, which is 70% reduction in third-year readmissions and 40% reduction in costs. And these programs are really proven to be effective and safe. And this is new in the US.
But what's the hardest part of that? Because something tells me it's not the technology.
It's not.
Right? Because people have different levels of comfort with technology,
Correct.
with using it. What do you have to do to make that work?
The hardest part for programs to launch for acute care in the home is actually, quite frankly, the design and implementation of the program, which is the team. How do you tell a clinical care team that's been used to practicing in the hospital side by side in a confined environment with all the tools and technologies available to them to now actually practice medicine at a distance? Like, that's a pretty big mental mind shift, right? And to do that in a way that you can't touch and feel the patient 24/7, not be 10 feet away from you, is very, very difficult. So I think programmatically, it's very hard to launch such a program. And the second big important piece is logistics. How do you get all these services, your oxygen delivery, phlebotomy, blood draws, imaging, x-rays in the home? How do you do all these things in the home in a timely manner? If somebody gets sick, they gotta be transported back to the hospital. So it's just a logistical nightmare to coordinate all these services that they're available to you in the home when you need it. So a lot of the challenges for building a program for hospital at home is a combination of all the services, the vendors, the coordination of timing, as well as the technology for safety monitoring.
Right.
And that's what we've built.
So, Deena, how many of the innovations that you see that either you're funding or thinking about funding actually deal with that issue where it's not so much the technology that's the challenge, it's targeting solving the right problems, the culture, getting the team to think about the approach differently based on what the patient really needs, maybe outside of the traditional setting?
Yeah, it's a question I think about a lot, because for those of you that are familiar with Lux Capital, we've been around about 22 years, we're known for investing in deep tech. We started off doing nano and nuclear and robots and drones, but we're also deeply interested in the advancement of human health. And sometimes that involves crazy cool robotic technology, and sometimes it involves getting back to fundamentals. And so when I look at a company and when we think about making investments, I don't want to see an innovation for the sake of innovation. Like we've all seen those. We've seen these crazy cool robotic gadgets that don't actually advance health and that providers don't want to use and patients don't understand. So the innovation isn't necessarily always technological. Telehealth has been around since carrier pigeons. There's nothing technological about it. It's just the idea of not being physically in the same space with somebody who's providing care for you. But that being said, the proliferation of these technologies allows us to care for patients in maternal health deserts who have no physical access to actually go see a provider, who can provide you point of care solutions, who can now do point of care testing in a way that was previously inaccessible. That's allowing care for millions of individuals who previously did not have access.
And Neel, Deena mentions telehealth. What have you at Maven seen about the uptake of that and effectiveness of that for populations that in the past might not have accessed health services available at the same rate?
Yeah, I think there's a lot of assumptions about technology literacy that just don't hold up when it comes to, honestly, like most people in 2022 want to be able to text a doctor or a trusted caregiver and get an answer back in a timely way. So I think, in fact, one of the things that's a challenge is in a digital paradigm, you don't have a captive audience. So you have to make sure that you're designing an experience that's engaging, and it turns out it's quite possible, particularly among pregnant people who are like giving up sushi and alcohol. Like they're very discerning, they're very elastic market. But just to go back to something that Deena said, like nobody at Health is splitting the atom. Like, the dominant cause of suffering in 2022 is not lack of knowledge, it's lack of execution on the knowledge that we have. And an app will not fix healthcare, right? Like, that's not what we're doing. We're creating portals into human services at the end of the day, and that's the hard part.
Yeah.
I was going to make a comment to your previous question. If you think about the fundamentals on the technology side, if you think about the definition of health, fundamental is like it has to be affordable, acceptable, and accessible. That hasn't changed with or without the pandemic and economic shifts, right? We still have problems with access to care and affordability. So when you think about technology, at least for us, it's always like, can you use technology to actually close that gap in terms of accessibility that Deena mentioned around distance or affordability? And that's really where the value is, and that doesn't really change with the economic downturns, like you were saying with the weather, because those are still realities that we're all facing today in the US or globally.
Well, let me ask you more of a businessy question. I was talking to your co-founder a few months ago, and I got the sense you guys are moving to be kind of a consolidator, right? So, and right now, some valuations are coming down. Some companies might not have the same ambitions of going it alone that they used to. What's the role of scale at this moment and in this economy? Why is that important?
I mean, for all startups, and I would say for Biofourmis, but probably for everybody, the reality is that in this environment, you got to prove two things. One is product market fit, and two is unit economics, right? What's the profitability, path to profitability? But the third for us is, if you think of the fundamental thesis that Biofourmis started with, which you think about, care is moving out of the brick and mortar to the home environment. That's the shift that's happening everywhere, given some of the consumer demand, financial pressures, and a lot of other things, and technology availability. We don't want to create the same fragmentation of care that exists in brick and mortar virtually. So in order to provide comprehensive care to a patient population that has multiple comorbidities, you have to think about the breadth of offerings across different clinical disciplines and across different services. And we, as a company, can't build every single aspect of that care model across multiple diseases, multiple specialties. So at some point, either partnerships or consolidation or acquisition is the only way to get there fast enough to prove the scale that you look for, to get the unit economics to work out in your favor. We can start taking risk on these populations and prove the model out, the product market fit. So I think that's how at least we're addressing the challenge.
Okay, now if you're like me, you're itching for Q&A right now, and it's killing me that I'm not going to give it to you, but here's why. Let me tell you why, right? The Q&A happens after the panel because that's part of the Spark model is that, we connect to each other. So you got your Qs, hold on to those. They got the A's up here. We're going to continue to do that in a period after the panel is over, but it's killing me. Like, I want to be, but I'm not going to, because we're going to go through this, spark the conversation, and then get back out. Neel, when you are looking at the progress that has been made specifically for the core populations that Maven serves, what's happened over the last couple of years, right? I saw that Kate talked a little bit about this in the write-up around your Series E raise. And do you have specific targets, goals for a next phase?
Yeah, 100%. I mean, I think part of the not splitting the atom thing is, like, at the end of the day, if you're just being very simple about this, the way to make care better for people is to find people who need more care and support and give it to them. Like, that's the whole thing, right? So, like, the point of this investment round is to, move into Medicaid, which, by the way, the hard thing about that is making the unit economics work. That's a worthy problem. Similarly, trying to create parity in global fertility benefits. But at the end of the day, I've got to say, like, for women's health in general, we're living at a moment of acute regression, right, over a half century. And also, I can't help but be an optimist because of rooms like this where there's a lot of investment in innovation on the delivery system side. And just to give you one specific example, the model of prenatal care in the United States of America is a century old. It has not changed. Like, we have ultrasounds now, we have all kinds of technology, but 14 visits in 9 months was the design from early 20th century. And then all of a sudden, during the pandemic, we were like, maybe pregnant people shouldn't be coming into clinical settings. Maybe, right? And there became 1,000 natural experiments for how to do prenatal care, like, overnight. And now Maven is in a place where we're reinventing what that looks like.
Deena, what's the role of consumer-facing technologies in this? And Maulik, I want to get to you on this too, because you were working at Amazon on Halo before this role that you're in now. But the promise of the Apple Watch, of things that Amazon and Google and others are doing, is just this mass collection of health relevant data in a way that's going to provide insight into what's happening and perhaps more rapid learning, frankly. To what degree is that happening? And is that happening in a way that's checking the privacy boxes and the security boxes that are so important in this arena?
Yeah, John, as you know, I really started my foray in healthcare at Google, so I have some thoughts on this. And to be intellectually honest, I think I would have answered this very differently just a few years ago. I've got this, I've got this. We've got some of those here on stage. I think it is still very early days, but we've come a hell of a long way from the initial Apple Watch. The fact now that Apple Health is doing something that Google Health tried to do back in 2007, but actually aggregating our health information. The fact that in California you had a digital vaccine card with a QR code that could just show, these, again, not rocket science, but basic rights to our health information, which now, by the way, is actually federally mandated. That's a really big freaking deal. I think that's huge. And a lot of these companies that started off as consumer wearables are actually doing clinically validated, peer-reviewed work to do everything from contraception with natural cycles, for example, recently partnered with Aura. The Whoop just, I think last week, announced that they're able to detect preterm labor. So there's a lot of really interesting emerging research. The extent to which folks like yourself on the clinical side will care or will look at it. I think if we have more Neels,
we
around
care.
the table, but you care. It's kind of cool, but I think it's starting to change. So I'm cautiously optimistic about that.
So what about it though, Maulik? Because you went from working more on the consumer mass side to really targeted acute problems. How much potential is there for better use of that data, and what are the barriers?
Yes, I think let me start with this. I think there's a time and a place in a room for consumer devices to provide insights into your own body and physiology to patients or people who are trying to improve their health, right? But the fundamental fact is that if you look at the cost of healthcare, the bottom 50% of the population in the US account for less than 3% of all US healthcare costs. So if you're working in the healthcare industry, that population of the worried well or people who just want to improve their sleep habits and their exercise and nutrition, it's great and it's going to help prevent complications later, but it's just not going to impact the cost of care. It's just not. So if you're trying to impact the cost of care to the complex population of pregnant moms and Medicaid and or people with heart disease or heart failure, it's the people who have the complex chronic conditions where the signals you need are truly medical device and physiological signals that truly matter to your disease process.
So you're saying the people who are really going to move the needle aren't the ones buying Apple Watches?
Absolutely. In fact, our common friend Krishna Yeshwant, about 8 or 9 years ago, to the beautiful slide at a conference, where he talks about on two axes, and if I got this right, social complexity, and the y-axis medical complexity. And everything that consumer health and wellness are doing in Fitbit, Amazon, Halo, or Apple is all on the low social complexity and the low medical complexity. Whereas all the cost of care is concentrated on the high medical complexity and the high social complexity. And what we need is solutions to really target that population, to really have an impact. It is the kind of impact we want to have in this room. I think that's part of the reason I transitioned from Amazon to Biofourmis, is try to work on those complex problems. And of course, the pandemic accelerated all these things around digital care and virtual care. But I think that's the fundamental conundrum between the wellness world and the care delivery, the healthcare world.
Neel, do you have a take there? What do we do about that?
About getting to the complex end of that spectrum? I think, honestly, it goes back to that simple, find people that need help and give them more of it. But that's actually, what we're really focused on at Maven. Pregnancy is interesting because it's a dynamic risk state. You enter into pregnancy one way and you may be relatively well, but all the things that we screen for in terms of chronic disease management, they happen between the second and third trimester transition. And usually that's when people are least engaged because they're cruising, right? Few of you probably have built families together. Maybe not with each other. But in the first trimester, there's a lot of questions, a lot of engagement. And then when you get close to the end, there's a lot of engagement. But it's actually this moment of low engagement where all of the risks start to accrue. And there's sort of a 2x2 box in my head of how to fix all of healthcare. But there's people who need a lot of help and need less help. And there are people who are very engaged and less engaged. And if you can find people who are less engaged, who need a lot of help, and make them more engaged, you've like won all of healthcare. So the problem, I think, as I see it, is a targeting problem and a precision problem.
Deena, close us out just for this session. And keep your cues, right? Because eventually we're all going to be back down there to re-engage. But if you could get more deal flow or better look at a certain cohort or type of innovation that you think is going to move the needle, what would it be?
Companies that are ruthlessly focused on outcomes. At the end of the day, that's really all that's going to get our friends like Patrick Conway over there at Optum to care. That's going to move the needle around the populations that need it the most. And I think a lot of those may start off looking like consumer health companies, which, by the way, Maven did originally. But the more data, the more engagement, the more you can show outcomes, the more you get the key stakeholders involved, the more you get the populations that need it the most.